Welcome back, ladies and gentlemen. We'll be now moving on to the 9th Symposium on Asthma. This will be chaired by Consultant Respiratory Physician Dr. Ishant Pereira and Consultant Respiratory Physician Dr. Kirti Gunasekara.
We have 4 speakers for this important session in asthma, and the faculty includes 2 of our own speakers and 2 from overseas. Let me call upon our first speaker, Dr. Sumedha Samankanta. He is Consultant Respiratory Physician, Teaching Hospital, Polonnaruwa. Dr. Sumedha. We'll be talking on the value of phenotyping in bronchial asthma.
Good morning, everyone, and thank you, sir, for the kind introduction. And I must thank the College of Pulmonologists for inviting me to do this talk on value of phenotyping in bronchial asthma. So I'll be talking, my talk will be structured. First I'll have a brief introduction, then we'll discuss about phenotypes and how we phenotype and their biomarkers, and little bit about endotypes, because we can't talk about phenotypes without knowing about the concept of endotypes, and then finally in little bit detail on the value of the phenotyping. Right, so we know asthma is a heterogeneous disease, so it appears to us with wheezing, difficulty in breathing, diurnal variation, triggers and those things, but in fact the presentation, although it is similar, the molecular mechanisms and the pathophysiological mechanisms that are going inside the patient is quite varied. So because of the same thing, they respond to medications and our therapeutics in a different level. So what is a phenotype? So we know it is, by definition we call it observable characteristics that results from a combination of hereditary and environmental influences. So what we see is the phenotype. What happens inside you is the genotype. Right? So there are few, not really, there are many phenotypes that have been identified with regards to asthma. Few of these well-known, well-described ones, as for examples, we have early onset extrinsic allergic asthma, which is the prototype of asthma, and then we have the late onset eosinophilic asthma, aspirin exacerbated respiratory disease, obesity associated asthma, smoking associated, and also very late onset asthma, to mention a few of the phenotypes. So like I mentioned in the introduction, the phenotyping is by clinical assessment, where you find out the expression in your patient. But there are things that will support us in confirming or describing our phenotypes further. So these things we call biomarkers of phenotyping. So we test for the presence of different molecules or surrogate markers of the presence of different molecules of the inflammatory pathways of asthma, which we call biomarkers. So the presence of these biomarkers will help us in differentiating the phenotypes. So it is a biomarker is a characteristic that can be measured objectively, and it shows it's an indicator of a biological process that's happening inside. So for asthma, we have mainly two categories of biomarkers, which will measure the inflammation, molecules of the inflammation of the two pathways, the T2 high and non-T2 high phenotypes. So what are the possible, or what are the biomarkers that are available to test these two pathways? So we have the gold standard is type 2 biomarker. We have the sputum eosinophils, and then we can also measure the absolute eosinophil count in our blood, serum total IgE, and also serum specific IgEs. and we also have the exhaled nitric oxide. For the non-T2 high group, the biomarkers are still being discovered, actually being researched. So whether blood or sputum neutrophilia can be measured, whether these molecules of IL-6, matrix metalloproteinases, whether these can be measured, they are still not accepted, but whether these are possible biomarkers in these non-T2 high phenotype as well. So with the phenotype, with the clinical assessment, and together with these biomarkers, we can identify or explain our phenotypes better. So then comes the concept of endotype. So what do these molecules, what do these biomarkers really represent? So endotype is the molecular mechanism that happens in your body, which gives rise to the phenotype. So there can be many endotypes for a single phenotype. In other words, a phenotype can be seen, but the pathophysiological mechanisms may be varied. So there may be few phenotypes under a single, there may be few endotypes under a single phenotype. So these endotypes or the mechanisms are very different, quite varied. So they can be actually, like I mentioned earlier, asthma is a single entity syndrome. However, it is as varied as several diseases when we think about the endotypes. The mechanisms that the molecular mechanisms that happen are quite varied, so that they are as the phenotypes can be considered as even as totally different diseases from each other. So considering the phenotypes and endotypes, what are the clinical significance there? So how do these endotypes give rise to the phenotypes, and or how does it help in our clinical management? So we have the T2 high endotype, where the phenotypes will be the atopic, late onset, and aspirin sensitive respiratory disease. So these have different clinical characteristics. So the atopic one, the classical asthma features with the allergic sensitization, and they will also have good response to your steroids. On the other hand, if you take the non-T2 high endotype, where you get, for instance, non-atopic ones, so they are not very responsive to our treatments, and they are difficult to control asthmatics, right? So coming to the main topic, so what is the value of knowing these phenotypes? So what is the value of phenotyping? So phenotyping will help us, particularly in the patient group that is called the severe asthmatic. So that's about 5 to 10% asthmatic patients, where we use the GINA steps 4 and 5 in managing these patients. So these difficult to control asthmatics, or the severe asthmatics, will be much benefited by trying to phenotype these patients, right? So these inflammatory pathways, if we can explain better, if we can find out the molecules and everything, then we will be able to tailor our treatments better, so that the patients will have a tailor-made personalized medication. So the phenotypes will help us in demographic and functional features to describe how many patients in this group will have this type of phenotype. So therefore, what are the treatment options, what are the management options that we can have. Also, phenotyping will tell us about the prognosis, the prognostic value of each category of these patients, and it will tell us how these patients will respond to our treatment, and the phenotyping together with the endotypes or the biomarkers will help us it will guide us deciding on the biological therapies. All in all, with these all these 5 important components, it will ultimately help us in tailoring very personalized treatment plans for each and every patient of ours. Few examples. So if you take the eosinophilic asthma phenotype. So we know they will be, we can describe them as more male patients. They have a higher IgE levels, then there are more atopic features, there's a greater degree of airway obstruction, and they need more intense treatment, as well as they have a poorer asthma control. But that's not all. So this is eosinophilic asthma. But even in eosinophilic asthma phenotype, there are two endotypes happening. So they have, although the phenotype is eosinophilic, some of them actually do respond well to our treatment. So those are the atopic individuals. So the atopic individuals, they will have other atopic features like allergic rhinitis, and they have a better control of their asthma, and they the inflammation is moderate and they respond well. But at the same time, there's another group with very high eosinophilic inflammation. So this group, this phenotype, although they are also the eosinophilic asthmatics, they are hard to control, and they have much resistance to our treatment, the steroids. Then what about the obesity phenotype? So obesity phenotype, we know obesity is highly prevalent in asthmatics, and it is associated with poor asthma control, and also it increases the risk of severe asthma. So we can predict by knowing these phenotypes how their disease will behave. Then therapeutic implications. So we know again the eosinophilic type will, if we know the eosinophilic type, then we can target to reduce the eosinophils, and that will help to reduce the exacerbations. If you get the smoking phenotype, the smoking cessation will be more efficient than trying to manage these patients with our standard the steroids and other medications. Smoking cessation is more efficient in managing these patients. Also, smoking affects their response to our standard treatments like leukotriene inhibitors as well as the steroids. Then if you take the obese patients, the therapeutic implication is obviously weight loss will significantly control their asthma. There are a few other things also in these phenotypes that can that has therapeutic implications, like if they have the persistent or chronic bacterial infections, they have rather resistance to treatment, and obesity, as well as there's some evidence even the vitamin D deficiency will have implications on how they respond to our treatment. Then what about the prognostic and predictive value of these our phenotypes? So sputum eosinophilia, if the patient is having sputum eosinophilia, it will indicate that they will respond to your inhaled corticosteroids well. Then the exhaled nitric oxide, then that will also, similar to the sputum eosinophilia, it will also predict, it can predict so the responsiveness to steroids. So if we know these phenotypes, we can prognosticate, okay, that this patient will be responding well to steroids, so that we can tailor our treatment. Then it will also predict our response to biologics, because we will know the phenotype, and knowing that phenotype, we can decide on which biologic to use, and we will also be able to predict how these patients will respond to our treatment with biologics as well. Like the pheno will be a predictive marker of dupilumab, which will help in reducing the exacerbations. So these are few of the biologics which will which we need to use phenotyping to decide on which biologic therapy that we need to use. So depending on our endotypes, the biomarkers, there are several different biologics that we can be used to manage our asthma by phenotyping, and then going further with biomarkers and endotype. Right. To summarize, so phenotyping together with the biomarkers and endotyping, it will help better understand the syndrome of asthma. Because asthma, although we call it with a simple umbrella term, it in fact is as different, as diverse as a cluster of different diseases itself, because there are so much different molecular mechanisms happening in each individual patient with asthma. So it will help us in deciding what treatment to give, what is the best treatment for these patients to give, and how these patients will behave in response to our treatment. Whether we need to escalate our treatments early, whether they will respond to our usual management, or whether they are candidates for advanced therapies like biologics and immunotherapy. So ultimately what phenotyping will do, particularly in the patient group of severe asthmatics, which is about 5 to 10% of all our asthmatics, what it will help is to design and give our patients very highly targeted therapies which are quite personalized to each individual. Okay, so that ends my brief talk on value of phenotyping in asthma.
Thank you very much, Sumedha, for keeping to time and also being very clear about your presentation. There was absolute clarity in your presentation, simplifying the complex topic of phenotyping in asthma. I think we will take the questions at the end of the session, and we have just a couple of minutes, I think. Yes, so we will now proceed on to the next topic. So the next topic would be tailoring the treatment of asthma, step up and step down treatments, which is a very useful topic by Dr. Harjit Dumra from India. Dr. Harjit is the consultant interventional pulmonologist, sleep medicine and critical care specialist, head of Department of Critical Care in Sterling Hospital, Ahmedabad, India. So over to Dr. Harjit Dumra.
Good morning, friends. At the outset, I would like to thank the Sri Lanka College of Pulmonologists for inviting me here for this session. I would begin by apologizing. One, I'm not physically present, and two, I have a bad throat, so please bear with me if my voice crackles up. I'll just begin with a few statistics about asthma in Sri Lanka. This was interesting because I looked this up. Asthma, in fact, is the 7th leading cause of death in Sri Lanka, and it basically accounts for around 6% of your total deaths. And Sri Lanka ranks 10th in the world in the list of asthma deaths, which is a pretty high number, clearly indicating that asthma is responsible for quite a bit of disability and mortality in Sri Lanka. And I suppose one way to address this issue is by increasing awareness and improving management of asthma in your country. And I think these sessions will go a long way in helping us achieve that. So with that bit of introduction, I'll be using a case vignette to highlight some of the important aspects of asthma management in 2023. So this is my patient, Mr. Janak. He's a 36-year-old chartered accountant. He's been having symptoms of sneezing and rhinorrhea quite frequently since childhood. In the last few years, he started developing breathlessness, which is almost 3 to 4 times a year. These symptoms have worsened over the last 6 months, and now he has persistent shortness of breath and cough. He also wheezes from time to time, particularly at night, which disturbs his sleep. He says that he has been adherent to his medication, but in spite of that, he coughs on more days, almost every day of the week, and frequently at night. He's diagnosed as asthma by his physician, who has started him on sustained release theophylline and montelukast, which is around 5 milligram dosage. He's also been prescribed a formoterol budesonide 100 microgram strength to be used as and when required. Over the past 3 months, he has averaged at least 2 daily doses of formoterol budesonide for rescue relief of asthma symptoms. Recently, he had an acute worsening following a viral infection, for which he was prescribed the course of systemic steroids, prednisolone 30 milligrams per day for 5 days. There are other important issues in this patient. He is an obese gentleman. He has been prescribed a spacer but hardly ends up using it. He has been exposed to passive smoke because his father, who stays with him, smokes quite a bit. He has a pet. It is a parrot whom he is extremely fond of. There is family history of asthma and seasonal allergies, and these are his common triggers. He also has some comorbidities, and he complains of fullness of stomach and heartburn frequently, and this tends to worsen his asthma. The bottom line here is, how would you manage this patient? So at the outset, the first and the most important thing when a patient walks to you in the OPD for a problem like breathlessness, which is diagnosed as asthma, you need to assess the control. What is control? The control is the degree to which manifestations of the disease are reduced or removed by therapy. So these are some of the points we look at to identify how well controlled or uncontrolled your patient of asthma is. These include daytime symptoms, limitations of activities, nocturnal symptoms, need of reliever. We also look at lung functions and the frequency of exacerbations. So any patient who has more than a few of these will be labeled as uncontrolled or partially controlled asthma. So obviously our patient is not doing well. He has quite a bit of symptoms. He's had an exacerbation as well. He has frequent nighttime awakenings and his lung function is also impaired. So obviously he has uncontrolled asthma. The second thing is, how do you optimize his drugs? So presently he is on formoterol budesonide with a sustained release theophylline and a low dose of montelukast, which I believe is inadequate for his age. Now, as all of you are well aware, there are two groups of drugs to treat asthma, the relievers and the controllers. The relievers are the long-acting, the short-acting beta-2 agonist and the long-acting beta-2 agonist, which have fast onset of action, and the controllers are by and large your inhaled steroids. There are other controllers as well, which includes montelukast, theophylline, and now biologicals as well. But for the session, for this particular session, we'll focus on inhaled steroids. So till 2019, this was the step-based approach to the management of asthma. So when a patient comes to you with mild symptoms, which are occasional, you would usually start with the short-acting beta-2 agonist, and that is step one of management. And from step 2 onwards, instead of SOS salbutamol, your drug of choice would be an inhaled steroids, which you would increase from low to medium to high dosages depending on the need to control symptoms of the patient. Now this management algorithm had quite a few paradoxes. To highlight just a few, for example, in step 1 treatment, although asthma is a chronic inflammatory disease, there was no mention of use of anti-inflammatory therapy. So short-acting beta-2 was the only drug prescribed, in spite of the fact that short-acting beta-2 is just a bronchodilator. In the second step, the patient was asked to stick to a fixed dose approach and graduate to a persistent daily inhaled corticosteroids, while in step 1 it was on SOS use, which meant the patient initially was told to decide on his own and subsequently was forced to do what his doctor used to tell him. This used to create a lot of confusion in the mind of the patient. Thirdly, there was an emphasis that from step 2 onwards, you should not be using your short-acting beta-2, but you should be persistently using your inhaled corticosteroid. And that was a switch not only for the physicians, but also for the patients, again making management a little confusing. And lastly, although short-acting beta-2 use in step 1 was considered safe to an extent, but as soon as you graduate to step 2 and onwards, where long-acting beta-2 agonists were being prescribed, it was clearly mentioned that they should not be used in isolation. They should usually be combined with inhaled corticosteroids, and isolated use of long-acting beta-2 was associated with a lot of safety issues, and that also created a lot of confusion. Now, with passage of time, all of us have known that excess use of short-acting beta-2 is associated with a lot of side effects. In fact, using more than 3 canisters of salbutamol per year is associated with higher emergency department visits, and using 1 canister per month or 12 per year is associated with a high risk of death, clearly showing that uncontrolled asthma and excessive use of short-acting beta-2 in these groups of patients can lead to high mortality. Also, what we tend to forget is when we label a patient as mild asthma, we believe that his symptoms are mild, and even if we tend to ignore those symptoms, these might not necessarily lead to disability or death. In fact, that is far from true. Patients with apparently mild asthma are at increased risk of serious adverse events. In fact, around 30% of patients of adults with acute asthma, around 16% of patients with near fatal asthma, and 15 to 20% of the total patients dying of asthma have symptoms less than weekly in the previous 3 months, clearly indicating that they have mild disease, but it can lead to catastrophic effects, clearly saying that mild asthma can also have disastrous consequences, and hence mild asthma also needs to be controlled. And hence, in asthma management. From 2019 onwards, based on the evidence gathered, GINA clearly said that any patient with asthma should never be on isolated short-acting beta-2 treatment, whether it is in step 1 or onwards. Every patient should be on inhaled corticosteroids because inhaled corticosteroids reduce the risk of severe exacerbations from mild disease to severe disease. And hence, all patients should be on ICS-containing controller treatment. The ICS can be used in two ways. It can be delivered by regular daily therapy, or in mild asthma, it can be used on SOS basis, where it is usually combined with formoterol, which is a quick-acting, long-acting beta-2 agonist. So, from 2019 onwards, we have changed our focus from short-acting beta-2 agonists as our relievers to what we now label as anti-inflammatory reliever, which is usually in a combination with formoterol and inhaled corticosteroids. And this is because there is ample evidence which shows that when you combine these two drugs, even when they are used on SOS basis, it leads to significant reduction in asthma exacerbations, reduces the total need of oral corticosteroids, reduces the total need of inhaled corticosteroids in the long run, and it prevents use of excessive short-acting beta-2 monotherapy, which is associated with significant adverse effects. So in 2023, this is the norm. Salbutamol itself should never be used in isolation as far as possible, and your reliever should, as far as be possible, should be an inhaled corticosteroid with formoterol. So these are the guidelines from GINA 2022. I'll just highlight a few of these aspects in my subsequent slides. So the preferred mode of therapy is the track 1, where you basically are supposed to start with as need be ICS formoterol. This usually is the case with step 1 and step 2 with mild disease. And from step 3 onwards, you are on maintenance daily ICS formoterol, which increases in dose as you move from step 3 to step 5, depending on the severity of the disease. The reliever here is ICS formoterol. This is because we have now ample data which shows that this kind of therapy reduces the risk of severe exacerbations as compared to when we use short-acting beta-2 as a reliever. When we use it for step 1 and step 2, it is primarily on SOS basis. From step 3 to 5 onwards, these patients are on regular ICS formoterol, and they can also take an extra puff as and when required. And this is called maintenance and reliever therapy, the MART option. It should not be used when you are using a different ICS-LABA combination. For example, if you're on salmeterol fluticasone, or you are on salbutamol beclomethasone option, or for that matter, any other inhaled steroid combination, this SMART option cannot be exercised. So this primarily is used when you are using any inhaled corticosteroid with a combination with formoterol. The second is the track 2, where you are basically emphasizing that the patient should be on daily inhaled corticosteroids from step 2 onwards. And in step 1, whenever you take a salbutamol, which is the reliever in track 2, you should always follow it up with the inhaled corticosteroids. So this kind of therapy is primarily used for patients who have been stable and have not been showing frequent exacerbations and who will adhere to maintenance therapy. Remember, track 1 is designed because patients have been found to be non-compliant with regular inhaled corticosteroids. So combining it with the formoterol gives them immediate relief, and it also ensures that an inhaled corticosteroid is delivered at the same time, ensuring decreasing in frequency of exacerbation, improving asthma control, and maintaining lung functions. But for patients who are adherent on inhaled steroids, that therapy need not be exercised because these patients already are ensuring compliance and ensuring control of asthma. So for patients on track 2, regular use of inhaled corticosteroids with SOS salbutamol. There are other options which can be exercised. This includes sublingual immunotherapy, LTRs like montelukast and azithromycin. And always remember, non-pharmacological interventions go a long way in improving asthma control. And these includes physiotherapy, breathing exercises, avoid of exposures to particular allergens, and vaccinations, so on and so forth. So this is what I have told you till now. There are 2 tracks in GINA step 1 and 2. Usually it is SOS formoterol ICS, and from step 3 onwards, it is maintenance ICS formoterol and SOS ICS formoterol as per need. The drugs which we commonly use is budesonide formoterol, You have data for beclomethasone albuterol as well, in case that is your option. You can continue with it, but most of the data is for budesonide formoterol. So our patient who was on SOS formoterol budesonide 100 micrograms obviously was not doing well. So we switched him to now a higher medium dose of ICS formoterol and started using it as maintenance and reliever therapy. Remember, medium dosages of inhaled steroids are usually safe even in the long run, but anything exceeding 800 micrograms of budesonide or 1000 micrograms of fluticasone propionate are associated with side effects down the line. So try and restrict your dosages to medium dosages. What about theophylline? It's always been controversial as to whether theophylline should be used or not in asthmatic patients. I could dig up this nice data from 1995 where they showed that although theophylline is not your first option in treatment of asthma, but when you add it to inhaled steroid, it still has some beneficial effects. And in fact, withdrawal of theophylline in this study, which was seen in 25 patients, led to deterioration of asthma control, and it had therapeutic benefits at low dosages as well, clearly indicating that it is not only a bronchodilator, but also an immunomodulator. So this patient now was on formoterol budesonide 200 micrograms, 2 puffs twice a day, that is around 800 micrograms of budesonide, and he was continued on theophylline and montelukast. Now, what do you do next? Once you have optimized the dose, remember, choosing the right device, optimizing technique, and confirming adherence is the only way to ensure that the drug is deposited at the right site in the right dosages. And sometimes we have multiple options to choose from as far as devices go. The choice of device is based on age, comorbidity, and severity of the airflow obstruction. But in any given situation, an MDI with the spacer will suffice for every kind of patients, whether it is a pediatric or a geriatric patient, whether the patient has acute symptoms or chronic symptoms, and irrespective of the inspiratory flow rate. So when in doubt, an MDI spacer should be the go-to device for all your patients. So how long do we continue treatment, and if and when do we step down? Well, stepping down is not an easy option in most case scenarios. Usually, first and foremost, you need to ensure control, which means improvement in symptoms, no exacerbations, improvement in lung functions over a period of at least 3 months, and that is the only time when you think of stepping down. You should usually assess your patients every 3 months, in case of pregnancy every month, and in case of an exacerbation, maybe 1 week down the line. Only step down when asthma has been well controlled for at least 3 months. Choose an appropriate time, which means that the patient should be free of any respiratory infections. The patient should not be traveling, which means he should be able to access medical care in case he worsens, and preferably don't step down during pregnancy because it can lead to worsening. Remember, any patient who has risk factors for exacerbations, which could be anything like uncontrolled asthma symptoms, frequent exacerbation in the last 12 months, who has low lung function, who has poor adherence, is a smoker, has elevated FeNO, or is obese, or has persistent eosinophilia, these are the patients who can exacerbate when you step down. So in these groups of patients, please be careful when you step down. On stepping down, usually the dosages decrease by 25 to 50% at every 3-month intervals, and usually if that does not work out, you can step up again to the previous dose. Always remember, when stepping down, you have to provide an asthma action plan to all your patients, and that is the only way to ensure that these patients don't end up with an exacerbation when you step down. In most kind of patients, stopping ICS is not recommended because there is a risk of exacerbations, and usually the controller therapy, this is for life. So this summarizes what I have told you till now. Formoterol budesonide is usually your go-to drug in most case scenarios. If you have any doubt, this drug will suffice for all kinds of asthma. You can usually start with a medium to low dose, and you can really use the same product as a reliever. If your need for reliever is between 2 to 7 puffs a week, you can continue the same dose. And in case the patient is doing well, he's using less than 2 puffs of reliever, at 3 months you can step down to a lower dose of formoterol budesonide. And in case he's using more than 7 puffs per week, it means that the dose of the controller is inadequate and you can step up to a higher dose. In case that does not help you, then that is the time to refer to a specialist. So Mr. Janak was followed up for 4 months. He had done well for the first 3 months. However, he had averaged at least 2 to 3 daily dosages. of formoterol budesonide besides his regular dose for respiratory. He had been missing several days at work and he was no longer able to work out, and this was also the reason for his weight gain. His symptoms of rhinitis and GERD were still continuing to trouble him, and although he was taking his combination inhaler, that is what he claimed, regularly, but he would often miss dose. He still was fond of his salbutamol inhaler, and he used to carry it and use it as and when he felt the need. He was still not using his spacer regularly. So what do you do if the patient continues to remain symptomatic, a kind of patient like Mr. Janak, who claims he is adherent to his drugs, who is trying to follow your advice, but still continues to remain symptomatic? Well, we constantly review, assess, and adjust our medications as we move forward. So every few months, you need to reassess whether your patient is compliant with therapy and whether he is in controlled mode or not. When your inhaled steroids don't work, the first thing you possibly should think of, rather than increasing dosages or piling on drugs, you first and foremost confirm asthma diagnosis. What I mean by that is many times patients would be referred to you with uncontrolled asthma from a different physician or a family physician. And sometimes you would just pile on the drugs because his asthma doesn't seem to be under control. Occasionally, this patient might not have asthma. He might have other associated or mimics of asthma, which would never improve with asthma medication. So please bear in mind, confirmation of diagnosis with a peak flow monitoring or a spirometry, or most importantly, the history, goes a long way in ensuring that your patient improves. Secondly, you need to identify and treat contributory factors. Non-adherence and poor inhaler technique are very common in asthmatics. Around 30% of your patients are adherent to drugs, and only 40% of your patients have ideal techniques. Hence, emphasize and focus on education of inhaler technique and ensure adherence by education. That goes a long way in improving asthma control. The other two reasons why asthmatics usually tend to lose control is exposure to allergens and presence of comorbid conditions. You can see that there is a list of allergens that patients can deteriorate when they come into contact with these. It could be house dust mite, it could be pollen, it could be mold, it could be certain outdoor environmental pollutants, or it could be just medications. There is a study from the Journal of Asthma in 2014, which looked at a questionnaire where they clearly showed that more the number of asthma triggers, less was the asthma control. So anybody who had more than 5 triggers was usually uncontrolled, and the more the number of triggers led to more severe asthma attacks, more hospitalizations, and more misstays at work, clearly showing that in uncontrolled asthma, allergens should be looked for and avoided as far as possible. Comorbidities again are a common problem with uncontrolled asthmatics, and like you can see on this slide, there is a list of them. There is clear-cut data that if you don't manage comorbidities, whether it is obesity, rhinosinusitis, GERD, whether it is sleep apnea, vocal cord dysfunction, or anxiety, these patients tend to have more frequent hospitalizations, increased length of stay in the hospital, and sometimes can also lead to mortality. So our patient had several issues which were not being addressed. He was not adherent, so we counseled him regarding it. He was not using his spacer, so we ensured that he knew the technique and he started using it. He was not on optimal dose of Montelukast, so we increased it to 10 milligrams. His father was advised to stop smoking at home. We got him to relieve his pet. He had to give it up to his neighbor. We treated his GERD with PPIs, his rhinitis with inhaled nasal steroids, and we asked him to try and lose weight. In fact, whenever your asthma is not under control, going to increasing medications is not the norm. First and foremost, check inhaler adherence, check the technique, treat comorbidities, and practice allergen avoidance before changing or increasing dosage of drugs. Now, 6 months later, Janak was better. He was still noticing some symptoms, but he had improved. He said that he was adherent to his inhaled steroids. His budesonide over the last 2 months had been jacked up to a very high dose of 1600 micrograms. His pulmonary function test was better, but it still indicated obstructive disease. He had lost weight, but he was still quite heavy, and he still needed intermittent oral steroids. Now, this kind of a patient is not easy to deal with when you are on maximal dosages and you have optimized management. So are there any add-on novel therapies for these groups of patients? Well, this kind of a patient who has uncontrolled disease and who is on high intensity treatment, and you have ruled out contributory factors like adherence, inhaler technique, triggers, and comorbidity is a patient of severe asthma. And today, severe asthma constitutes 5 to 10% of patients of asthma who really are a challenge when they come to the OPD. So how do you go about managing these patients? First and foremost, you need to confirm diagnosis. Then you need to check for triggers and contributory factors. And only if these patients remain uncontrolled after this comprehensive assessment are they labeled as severe asthma. And these are some of the therapies which GINA recommends for severe asthma. It could be increasing the dosages of inhaled steroids. It could be adding macrolides. It could be using biologics, thermoplasty, or now we also resort to addition of LAMA therapies. So usually when you deal with a patient of severe asthma, you tend to phenotype this patient. Phenotyping is based on biomarkers, which is usually in the form of blood eosinophil counts, FeNO, sputum eosinophils if you have access to them, and the need for maintenance oral steroids. If you have high markers, it usually indicates type 2 inflammation, and biologics are the drugs of choice for type 2 inflammation. If not, you label them as non-type 2, where tiotropium, macrolides, oral steroids, or bronchial thermoplasty become the drug of choice. We have the availability of 3 biologics in our country in India. I'm not too sure about the availability in Sri Lanka, but I suppose even if they are not present soon, you will be having them. And it is best to brush up your details about biologics and which is the patient group whom you need to prescribe and which is the biologic you need to focus on in a given patient, because personalized medicine will go a long way in helping your patients. Mr. Janak was investigated further for severe asthma. His CT scan was done, which was normal. His absolute eosinophil count was 430. His FeNO was 26. His IG was 245. He was labeled as a patient of severe asthma with type 2 inflammation, eosinophilic phenotype, and he was initiated on a trial of mepolizumab. 6 months down the line, his exacerbation frequency and need for oral steroids had substantially reduced, and now his exercise tolerance and quality of life was significantly better. Finally, this patient was doing well, and we had achieved control. Moral of the story, keep on trying. Asthma can be difficult, but it usually is controllable. The last bit about the future of asthma management, this is where I would like to focus on. This is the space I would like you to watch for in the future. Now we have access to ultra long-acting beta-2 agonists. We have 2 of them, vilantrol and indaketrol, which have been combined with once daily inhaled steroids, fluticasone furoate and mometasone furoate. The benefits of these combinations is that you can conveniently dose them once a day, and these inhaled steroids are safe and equally effective as the pre-existing inhaled steroids. And the best part is that most of these long-acting beta-2 have quick onset of action. Say for vilantrol, the onset of action is less than 4 minutes, which is almost equivalent to formoterol. So where are we going with this? At present, GINA does not mention where you should use these alpha-LIBA ICS combination. But data from the Salford lung study, which was published in the Lancet in 2017, clearly showed that when you use one of these combinations, fluticasone formoterol, fluticasone furoate with vilantrol was the drug which was tested in this study, it clearly showed that it worked better than the pre-existing ICS-LABA combinations we have at this point of time. So in the future, this is what I envisage asthma management would look like. Right now, I showed you that I would focus on this particular drug, formoterol budesonide, and go with track 1, that is use maintenance and reliever therapy, focusing on this particular drug to step up and step down management. In future, my asthma management would be more track 2. Remember, track 1 is designed because patients of asthma are not adherent with regular inhaled corticosteroids. And that is why you need to give them an option of SOX use, and that is where the maintenance and reliever therapy came into the picture. But if the inhaler steroids and ultra-long-acting bronchodilators, which are available as of today, can be used just once daily and they ensure good control and low side effects, in fact, less side effects, then I suppose the management would be very simple and track 2 would be the way to go. You would usually start with once daily vilantrol, fluticasone, or indaketrol, mometasone. And if the patient continues to do well, you can continue the dose. If the patient improves over the next 3 months, you can step down to a lower dose of fluticasone or mometasone. And in case the patient is not doing well, now you have single inhaler triple therapy. Well, all 3 drugs, a LAMA, an ICS, and a LABA, are combined in one drug and in one inhaler, and they can be given just once daily, ensuring adherence and hence ensuring control. So it makes our life as chest physicians extremely easy. You start with once daily therapy, you end with once daily therapy. And this is where the future of asthma lies. Once daily therapy will become the norm in the near future. I thank you for patiently listening, and I'll be open to questions. Thanks a lot.
Thank you, Dr. Dugma, for the excellent talk on stepping down and stepping up of treatment of asthma. I think it's very valuable for the Sri Lankan audience, that we have been, many of the practitioners have been practicing the same doses, like without stepping down or stepping up. That was one of the problems. I'm sure the audience will be having many questions, but we'll take up the questions at the end of the session. So let's move on to the third speaker. He is Professor Philip Gerard from Belgium. He is an ENT specialist at the Department of Otolaryngology at University of Ghent, Belgium. He will be talking to us on the impact of upper airways in bronchial asthma. Over to you, Professor Gerard.
Hello, ladies and gentlemen. I'm Philip Gerard from the Ghent University in Belgium, and I will give a talk about the impact of the upper airways in bronchial asthma. These are my disclosures, and I am an ENT surgeon in Ghent, Belgium, and actually I was lucky to be raised and educated in a center with a lot of experts. My colleague Klaus Bakkert, also very known in the field, and I have also working every day with some interesting lung physicians. Now, on Monday I do surgery, on Tuesday I work on the lung department, and on Wednesday I work on the ENT department. But when I work on the lung department, I work together with Professor Guy Bruxelles, who is a highly recited researcher, with Professor Guillaume, who was a past president of the European Respiratory Society, and with Professor Bart Lammert, who is a very highly cited researcher and very good investigator. Now, when we have this multidisciplinary nose-lung consultation, I see that there is different kind of things that we see. We mainly see patients with severe nasal problems, such as severe chronic sinusitis with nasal polyps, and some of these patients might have asthma. On the other hand, the lung physicians, they see patients with severe asthma, and some of them might have nasal polyps. Of course, we also do have a group where they have severe asthma and severe nasal polyps, but most of the time it's it's not always severe in both of the airway. Now, when we are there, we try to make the choice between the optimal medical treatment for upper and lower airways. Sometimes I need, as a surgeon, to do surgery to clean the noses, and nowadays, in the last years, we now have the option of treating with biologicals. I will start with this case. This case is a man. He's allergic to everything. He has a blocked nose, rhinorrhea, postnasal drip. His sleep is very much disturbed because of his blocked nose. He's snoring. He's tired all day. He has a nightly cough all year round. When I ask him, do you have asthma? He says, no, I can't breathe, I can't breathe. So he doesn't really know. Now, when I listen to what he takes as medication, he tried antihistamines, he tried nasal corticoids twice a day, but if I listen very careful, he uses this fast decongestion, so overuse of decongestion since many years. And now and then, when not everything is going well, when he's coughing, when his nose is blocked, the general practitioner gives him a shot of the depot systemic corticoids. When I look in the nose, I see that he has a septal deviation, a spur. When I take a CT scan, I see he has no sinusitis, but he has a very blocked nose by a septal deviation. When I do skin prick test, he has a house dust mite allergy. The IgE is increased, and the specific IgE to house dust mite is also increased. When I send him to the lung physician, he has a mild obstruction. He has an increased FeNO of 56 ppb, And the lung physician also did a polysomnography, so a sleep test, and he has an apnea index of 21 apneas per hour. So this patient really has a combined problem, and that makes it always harder to treat. So when you have a patient that is uncontrolled, you have to look a little bit broader over your own field and look whether there is a nose problem, whether there is a sleep problem, whether there is a lung problem. So in this place, the patient has a global airway disease, nose and lung. He has a nasal hyperreactivity. He reacts to almost everything, to perfumes, to air conditioning, as a result, of course, of the underlying allergy. And he also has many things like septal deviation, asthma, sleep apnea syndrome. And on top of that, he's misusing medication. So he overuses nasal decongestions. In that way, the nose is always blocked as a result of the overuse. And because of that, he doesn't use the nasal glucocorticoid spray in a good way. So this patient has a combined problem. We see in studies that nasal corticoids are quite often the solution, but patients seems to use them not in the correct way. So trying to teach your patient that the nasal corticoid is a good one and the nasal decongestion is the bad one, and then trying to explain that the nasal corticoid, you need to do it long term, and you have to shake it, you have to look forward, you have to point away from the septum, that is quite often not done by the patient. We see that a lot of patients are under-adherent to nasal corticoids, although that's the golden standard for nasal treatments. Also, we see that in Belgium, that many patients, 3% of the patients with just allergic rhinitis, still use systemic steroids on a regular basis, and that is also not good. So we need to do better. Because we know that the use of systemic steroids for something like allergic rhinitis is not good, and you have on the long term osteoporosis and diabetes when you use systemic steroids. So what did we do in these patients? We tried to educate him to stop the decongestions, which is not easy. So we did also a septoplasty and a turbinate surgery to make the nose open, and then he could stop the decongestions. Because of the sleep apnea, he needed a CPAP machine, so for positive pressure to take away the snoring and the apneas. And for treatment, we learned him to use nasal glucocorticoids, nasal antihistamine, inhaled glucocorticoids for the lungs. And actually at the end he said, yes, that is now going well, but do you have something more definite for the house dust mite? So we give him house dust mite immunotherapy, which could then, after that, he could take less of all the other medications. And what is interesting here is that recently there is a lot of evidence that if you take house dust mite immunotherapy, that this has also not only good effect on the nose, but also on asthma exacerbation. So in this study with house dust mite immunotherapy, you see that actually the patients on house dust mite immunotherapy had less severe asthma exacerbations over time. Now I want to present you a second case. It's a woman of 34 years old. She's an artist. She has house dust mite allergy since childhood. And when she was 24, she had severe respiratory complaints with nasal polyps. As you can see, the CT scan, there's a lot of nasal polyps there, with nasal obstruction, no smell, postnasal drip, hyperresponsive to alcohol drinking. And she got a sinus surgery in 2007 and then in 2008. Also, asthma was diagnosed. It was all done in another hospital, but the patient had no idea that the nose and the lungs were connected. So in 2011, she came to the University Hospital in Ghent, and we explained her that the nose problem, the chronic sinusitis with polyps, and the asthma, there was a connection. For her, that was something special, that she now understands that upper and lower airways was the same kind of disease. When she came to us, she had no further exacerbation under an ICS LABA, but she still was responsive to non-specific stimuli. Her lung function was always quite good, although some years later she had a severe asthma exacerbation which required hospitalization for 2 weeks, which is quite bad. We don't see that now so often anymore in Belgium. And the lung function really dropped, the FEV1 to 49%. And she was in a really bad shape. The blood eosinophils raised for 58%, which is really high, 3,528. And she had a specific IgE to Aspergillus fumigatus and to house dust mite. ANCAs were negative, and so we checked on that as well. And we gave her oral steroids and a high dose of ICS/LABA. And what you can see is that the eosinophils were really high, and they dropped, of course, when we started treating with the oral corticoids. Now, after that, the patient was uncontrolled, and we take a CT scan, was full with polyps, and we tried to convince her to do another sinus surgery, because she said, well, I already had to, so I don't want to do that. But we convinced her to do the sinus surgery because the lung physician said, really, you have to do something about the nose. And during the sinus surgery, we saw this typical Charcot-Leyden crystals and eosinophilic thick secretions. And actually, the patient was doing better. But after 1 year, the nasal polyps started growing back, and the asthma was getting, again, not under control. So we were happy in that patient that we could start an anti-IgE treatment. At first, that would not have been possible because the IgE was too high, but because we did the surgery, the IgE dropped. And so that shows that when you do the surgery, you can take away the source of the inflammation. And nowadays, in 22, actually the patient is very well under control, both the upper and the lower airways, by working together the lung physician and the ENT surgeon. Now I want to tell you a little bit more about nasal polyps. You have chronic sinusitis without polyps, with polyps. With polyps, it's a different kind of disease because there is a strong association with asthma and also with NSAID, exacerbated respiratory disease. So those nasal polyps are very strongly associated with asthma. And when you look in biopsies in tissue, we know that chronic sinusitis without polyps is quite often a type 1 disease with little eosinophils. When you look in nasal polyps, it's a type 2 disease with a lot of eosinophils, with a lot of IL-5, with a lot of IgE. So if you look in the nose without nasal polyps, the CT quite often is not totally blocked. When you look in the nose with polyps, you see the polyps and you see that the CT scan is fully blocked. There is also a difference in symptoms. If you ask chronic sinusitis patients what are the symptoms, typically they have this facial pain and pressure and headache and congestion and postnasal drip, but it's rarely associated to asthma and to blood eosinophilia. Nasal polyps, they might have a pressure, it's not really pain, but they really have loss of smell. So they have no smell at all. So if you are a lung physician and you don't have an endoscope to look, you ask to your patient, do you have smell, yes or no? If your patient has no smell, the chance is really high that your patient has nasal polyps. So you can also test blood eosinophils, and you see that nasal polyps is always associated, or at least in Europe, with high eosinophils, with asthma, and with this aspirin hypersensitivity. Now, how does this work? It's not an allergic disease, but what do we see is that there is a barrier dysfunction. You have a chronic microbial trigger, for example, with superantigens, Staphylococcus aureus superantigens, and they stay there to trigger your system. They can give you a hyper IgE, a lot of eosinophils, and then you get this polyp formations. And those Staphylococcus aureus take advantage to be disease amplificators or modifiers. Now, what is the classic treatment? The classic treatment is nasal corticoids. You can give the nasal corticoid spray. The problem there is that it reduces the symptom, but it doesn't reduce the progression of the disease, and it doesn't reduce the need for surgery. There is an exception on that. If you give not only the spray, but you give corticoid rinsments, or you do give these drops, and you let the patient hold the head in a different position, here, like you can see here, and you do the drops inside, then you see that you have a better effect, because with the spray you don't get where the origin of your nasal polyp is. So when you do this kind of technique, then you have less nasal blockage, you have a decrease in polyp volume, and you also have less need for nasal surgery, which is already one step forward. Also, you can prescribe systemic steroids, oral steroids, but quite often they are used very often, and the effect is very short. We did a double-blind placebo-controlled trial, and what you can see here, if you treat 20 days with an oral corticoid, that the effect is very good on nasal polyp score, on the loss of smell, on nasal congestion, but as soon as you stop, the symptoms turn back. So the effect of systemic steroids on nasal polyps is quite short, so we need to have better tools here. What about surgery? I think surgery is the cornerstone of a treatment of nasal polyposis. We did a long-term trial over 12 years, and what you see is that over 12 years you have a nasal polyp recurrence of 80%. You can say that's a lot, but that is any kind of polyps, also small polyps. And it's not because you have polyp recurrent that you need a revision surgery. We also found out that 21% of our patients were cured from the disease, which is also a good thing. But the most interesting group is the group which is 37% that over 12 years needed revision surgery. And I think this is the group we need to see. Overall, this surgery was quite successful in reducing the symptoms. So you see nasal blockage, and most of the symptoms really were well controlled after 12 years. The only thing which was very hard to control is the smell disturbance or the loss of smell. As you can see, you have a better trend, but so it's even significant, but still at the end around 60% of the patients still have a severe smell impairment. Now, what about nasal polyp recurrence over time, over 12 years? You see that you have very fast recurrence, but you also have patients where the polyps recurred after, for example, 6 years. So when they have some kind of new event, a new cold that triggers this polyp formation. Also, the need for surgery. You have some patients where you have an early need of revision surgery, quite often after the surgery where polyps grow back. So that's one group. And then you have also a group where they grow slowly back. And for example, after 6-7 years, you have to do a revision surgery. Now we try to predict which patients that they are. Patients with allergy, with asthma, with aspirin hypersensitivity have more chance of needing revision surgery, but also those with high tissue IL-5, tissue IgE and IgE to Staphylococcus aureus enterotoxin had a higher chance for the need of revision surgery. So because of that, because we always have this 80% recurrence of polyps, 37% need of revision surgery, we need to have better options for our patients. So since 20 years I do research on the use of biologicals in nasal polyps, and of course these biologicals are widely also used for patients with extremely severe asthma. So we do have now trials with mepolizumab, dupilumab, omalizumab, benralizumab, and we are happy today that since very short in Belgium they are available for nasal polyps to treat, although they are extremely expensive. So really we should select the right patients that we don't have other options with. So what about anti-IL-5? I did the first anti-IL-5 study already more than 10 years ago, and we see that 2 injections were effective in almost 50% of the patients, so 50% of the patients were responders. Based on that, they did a bigger trial that was recently published, this big trial with mepolizumab anti-IL-5, and what you see is that the polyps, they shrink slowly. So it takes a time, it doesn't go fast, so after 52 weeks the polyps are getting smaller. And also the nasal obstruction and the SNOT-22 is a combined symptom and quality of life score, and you see that the quality of life and symptoms are also reduced over time. It goes slowly and it doesn't seem to have reached a plateau phase. Now another anti-IL-5, benralizumab. There was also a double-blind placebo-controlled trial, and that one worked very well on the asthma, but on the nasal polyps it was somehow disappointing. So this was a little bit of disappointment. We do not know yet why. We think it might be dosing, but we don't know. Another option is anti-IgE. You have in the nose this high local polyclonal IgE formation, can be really high. I did the first academic trial already, also more than a decade ago, and we saw that omalizumab in asthmatic patients that were allergic and non-allergic with nasal polyps, that the nasal polyp score was improving in around 65% of the patients. So based on that, there was this bigger trial with a double-blind placebo-controlled arm, then an open-label extension period, and then a long follow-up part. And what you can see here, and that is very interesting, is that when you treat nasal polyps, the polyps are shrinking away, and then if you continue the treatment, they get smaller. If you treat the placebo arm in the open-label extension, also with omalizumab, it gets better. When you stop the treatment, polyps start growing back slowly. Also, the SNOT-22, the quality of life, was getting better in those patients. And what is interesting maybe for lung physicians is that both the asthmatics and the non-asthmatic patients were equally reacting to the omalizumab treatment. And also interesting, because nasal polyps is an IgE-mediated disease, but not an allergic disease, is that we see that both allergic and non-allergic patients equally reacted to this anti-IgE treatment. Now, what about anti-IL-13/4 receptor antagonist? That's a quite new treatment, dupilumab, and we have done several trials with that. This is the first trial showing a good effect, but this is then the more known, bigger trial, the Sinus-24 trial, where polyps are shrinking, and you can see that the magnitude is fast and really good and high. And you see here, if you treat 52 weeks, that you have a good effect with dupilumab, and also on the SNOT-22 you have this effect. If you stop the treatment here after 24 weeks, polyps start growing back, and of course symptoms are returning. So it's very interesting to see that the nose and the lung are really connected. You have severe asthma, this can be connected with allergic rhinitis. You have severe asthma, it can be connected to nasal polyposis. And what we do know is that nasal polyps is really a predictor for persistence of adult onset asthma. So if you have a patient with nasal polyps with asthma, and the patient has also nasal polyps, it tells you that your patient will be a long-term patient for you, and that you will have to take care for many, many years to get the asthma controlled, which is different for asthma without nasal polyps. So in that respect, I think sinus surgeons and lung physicians have to work together, especially for the patients with severe airway disease. So I think United Airways needs also united guidelines, and we are working on them so that you can really have one guideline where you see as a lung physician, if the patient has nasal polyps, I have to do this. If there is no nasal polyps, I have to do that. If there is allergic rhinitis, you have to do a certain treatment regimen, and you have to take care of the allergy as well. So with that, I want to thank you for your attention, and I hope maybe to see you soon in Sri Lanka in person. Thank you very much.
Thank you very much, Professor Philippe Lebart, for the interesting talk on impact of the upper airway and bronchial asthma, particularly in an era where the inflammatory allergic airway diseases are becoming very common. So we will have, I'm sure there will be many questions, but we will keep it to the end of the session. And next, may I invite Dr. Chandana Kulatunga, Consultant Respiratory Physician, District General Hospital, Matara, to speak on the air we breathe and the respiratory health. Dr. Chandana Kulatunga is a person who has done a lot of pioneering work about air pollution in Sri Lanka, and it's a great contribution, Chandana, and over to you to speak on this topic on the air we breathe and respiratory health.
Thank you very much, sir, for the words of introduction. And within the next 20 minutes, I'll be talking on the air pollution and pulmonary health effects. So, air pollution is a major public health concern, both in developed as well as resource-poor countries. But unfortunately, in resource-poor countries, the issue is largely underestimated and under-evaluated. It's an invisible killer across the globe because, according to recent WHO statistics, 8 million people die prematurely. In a simple way, every hour, 800 people are dying. Poor air quality reduces global life expectancy by 1.8 years. But if you live in a more polluted city, maybe New Delhi from India, and Dhaka from Bangladesh, and maybe in Beijing, so reduction of your life expectancy definitely will exceed more than 1.8 years. So how do you define air pollution? Chemical or physical changes brought about by natural processes. So natural processes may be like volcanic eruptions or wind erosions, or due to various human activities, vehicle exhaust, and then the industrial exhaust, and the construction industry and various other the human activities, resulting in air quality degradation is defined as air pollution. So what are the harmful gases you breathe when your air is polluted? Ozone, nitrogen dioxide, sulfur dioxide, carbon monoxide, and volatile organic compounds. So you breathe gases as well as particulate matters. So what are these particulate matters? These will be non-gaseous substances suspended in the air. Basically, they are a complex mixture of extremely small particles and liquid droplets. The air pollution is measured by air quality index. For air quality index, generally, the air quality index is calculated for particulate matter levels, PM, for the purpose of comparison. For air quality index, AQI, you will be given a standard value as well as a standard color. When the AQI is in between 0 to 50, you are very safe. Standard color will be green. And AQI 51 to 100, by definition, moderate air pollution, but still you are safe. When AQI exceeds 101, then it's unhealthy, and sensitive group develop complications. So it's very, very important to identify this sensitive group. This group includes pregnancy, extremes of age, and patients with multiple comorbidities. But remember the cutoff, when the AQI exceeds 150, definitely it's the dangerous, unhealthy, and then the individuals will develop the various health complications. And this is the top 10, not the politicians, actually top 10, list of top 10 most polluted cities in the world. And if you just briefly go through the list, you can see this, most of the cities are actually from India, and then Nepal, Pakistan, and so this list is constantly changing, and there will be the competition in between countries like India, Bangladesh, Nepal, and then Afghanistan. Right, briefly I will discuss the air quality index in India because it affects Sri Lanka. We were very interested in the previous days. India is having a large agriculture-based economy. So towards the end of the farmers burn the tons of crop residues. They burn the tons of crop residues, and then the vehicle exhaust, industrial exhaust, and then the construction industry combined with the effects of climatic change, their air quality index become very bad towards the end of the year. And if you look at the tables below, so you can see in October, November, December, the air quality index is very bad. It almost exceeds 300. And then this smoke will slowly goes over Sri Lanka due to the changes of the wind, and then this affects the air quality of Sri Lanka. So this is the air quality index in Sri Lanka upper chart. You can see this was taken from the American Embassy, and if you look at clearly from the April to October, the most of the days of these months are green. So that means our air quality index is very good. But towards the end of the year and it extends to the beginning of the next year, the air quality index is bad. This is the actual effect of India. So this is actually the scientists and people began to talk on the human health effects of the air pollution following London smoke that occurred in 1952. It was actually, it's a very long winter. People used more and more coal to generate heat, and ultimately towards the end of December in 1952, the city of London was covered with a thick layer of smog, and it lasted about 1 year, one week, and 12,000 people are said to die during that week, and 100,000 people were admitted admitted to the hospitals due to various complications related to air pollution. Now let me talk about health effects of air pollution, but remember, your air pollution is not only going to affect the humans, but it affects the flora and fauna, and importantly, it destroys ecosystems. And these are the mortality statistics, mortality data, and the scientists have found that the individuals who were exposed to toxic dusts and fumes, most of them were actually died due to the macrovascular complications, vascular disease, 34% from stroke and 26% from ischemic heart disease. This is because when you are exposed to especially the particulate matter, carbon monoxide, and then the nitrogen dioxide, so they penetrate the alveolar capillary membrane and they causes inflammation of the blood vessels, and they increase the atherogenicity. Therefore, these patients, most of the patients, they died due to stroke and ischemic heart disease, and the rest of the patients died due to COPD, pneumonia, and lung cancer. Now let me talk on briefly air pollution and pulmonary health effects. So this could be either acute or chronic. So following acute exposure, the individuals can develop mild symptoms like sore throat, rhinitis, cough, wheezing, and these patients can develop fever as well. So most of these patients are treated as viral fever in the community. But the patients can die of pneumonia, especially patients with multiple comorbidities and the patients with the elderly patients. And existing lung diseases like obstructive airway disease, asthma, COPD, and idiopathic pulmonary fibrosis, their existing lung conditions can get worse following exposure to the nitrogen dioxide and particulate matter levels. And following chronic exposure, they can get new diseases or complications, especially children end up with low lung volumes, I'll be discussing later, and the individuals can develop asthma, lung cancer, even interstitial lung disease. First, I'll discuss pulmonary health in children. So children are more vulnerable to harmful effects of air pollution than adults, because their lungs are immature, their defense mechanisms are still evolving. Moreover, children have a higher minute ventilation, involve more in vigorous activities, and spend more time outdoors than adults. Lung function in childhood is a strong predictor for lung function in adulthood, and therefore an important health predictor. So let me discuss this very important landmark study. Children's health study in California. They studied the effect of air pollution on lung development from the age of 10 to 18 years. So this 18-year figure was because they followed the children until the age of 18 because their lung development or the lung become mature by the age of 18 years. It was a prospective cohort study, and they enrolled about 1,759 children from the various the provinces from California. The communities represented a wide range of ambient exposures to ozone, acid vapor, nitrogen dioxide, and particulate matter levels. And scientists did annual medical examinations and the regular follow-up of the spirometry. And at the age of 18, after a follow-up of 8-year period, the sex average analysis depicted by the regression line demonstrated a significant negative correlation between the growth in FeV1 over the 8-year period against average nitrogen dioxide levels. So it is obvious that when children are exposed to higher levels of nitrogen dioxide, their lung development is going to be affected. So these are the major results of the study. Air pollution harms children's lungs for life. Children exposed to higher levels of particulate matter, nitrogen dioxide, acid vapor, and elemental carbon had significantly lower lung function at the age of 18 and age when the lungs are nearly mature and the lung function deficits are unlikely to be reversed. So they end up with decreased lung volumes and related complications. So if you think of leading schools in Sri Lanka, so most of them are situated in the middle of the cities. And children living in high ozone communities who actively participated in several sports were more likely to develop asthma than children in those communities who did not. Children who moved away from the study communities had increased lung development if the new communities had lower particulate matter levels, and had decreased lung development if the new communities had higher particulate matter levels. Days with higher ozone levels resulted in significantly higher school absence due to respiratory illness. Now let me discuss the links between obstructive airway disease and air pollution. So obstructive airway disease, both asthma and chronic obstructive pulmonary disease, they are characterized by chronic airway inflammation. So whatever the etiologies, they will develop chronic inflammation and end up with airway remodeling. So in animal models, scientists have demonstrated the similar pattern of inflammation following exposure to these toxic dusts and the fumes. They develop airway inflammation and airway remodeling. So with this biological evidence, with this biological plausibility, I'll discuss some epidemiological studies which links air pollution to obstructive airway disease. First, COPD. Ambient air pollution was associated with lower lung function and increased COPD prevalence in this large study in UK. The scientists used UK biobank data on nearly about 300,000 individuals aged 40 to 69 years. The cross-sectional analysis examined association between COPD and PM and nitrogen dioxide levels. So exposure to higher PM concentrations was strongly associated with increased COPD prevalence and declined respiratory function. A similar study in China again showed that the significant clinical association between the air pollution and COPD. So these are the confounding factors they considered: low socioeconomic status, and then the other exposures like occupational exposure, obesity, and smoking. So there are enough epidemiological studies which shows the close link between acute exacerbations of COPD and air pollution. So air pollution is the primary non-infectious factor that causes an increase in the COPD-related mortality rate following acute exacerbations. Impact of air pollution on asthma outcomes. The prevalence of asthma is estimated at between 1 and 18% of the population in different countries. Evidence suggests that 13% of global incidence of asthma in children could be attributable to traffic-related air pollution, and data showed that air pollution has a negative impact on asthma outcome in both adult and pediatric populations. So remember, the air pollutants causes asthma as well as they affect the outcome of asthma. Lung cancer. Based on sufficient evidence, studies of human and experimental animals as well as strong mechanistic evidence, the International Agency for Research on Cancer, IARC, in 2013 classified both outdoor air pollution and PM in outdoor air pollution as a group 1 human carcinogens for lung cancer. IARC has also classified household burning of coal as a group 1 human carcinogen and household burning of biomass fuel a group 2A, probably carcinogenic for lung cancer. Anyway, these are the biological evidence. So I have discussed the epidemiological studies, and then these are the biological mechanisms for air pollution derived carcinogenesis. So especially vehicle exhaust contain the various carcinogens, especially the hydrocarbons, and the scientists have proved that these hydrocarbons cause the cancer in animals as well as in the humans. Air pollution and respiratory tract infections. Evidence that inhalation of combustion-derived material increases vulnerability to airway infection dates back to at least the 1952 London smoke, which I discussed, in which coal smoke was temporarily trapped over the city. The subsequent landmark paper, published a year later in The Lancet by Logan, reported that during the smoke, deaths from pneumonia increased threefold, with the very young and the elderly particularly at risk. Though following that, there were various epidemiological studies which links the air pollution and respiratory tract infections. The latest evidence comes from the pandemic, COVID-19 pandemic. So there are the large number of studies, the epidemiological studies, which shows the links between the air pollution and COVID-19. So air pollutants increases the number of the COVID cases as well as they increase the mortality and morbidity of established COVID pneumonia. So these are the possible mechanisms. The first, particulate matter causes chronic inflammation of the airways, and second, there are various other the explanations, and they impair the immunity. And interestingly, these particulate matters act as carriers for microorganisms. Scientists have demonstrated that the particulate matters can carry viruses as well as the bacteria. Right. The air pollution exposure is increasingly recognized as a risk factor for the development and the progression of interstitial lung disease. Preliminary evidence suggests that cumulative air pollution exposure are linked to preclinical interstitial lung disease. Further studies required to evaluate whether pollution modifies the risk of progression to ILD in patients with high attenuation abnormalities, how underlying genetics influence this risk, and whether imaging studies can be used for early identification of subclinical ILD in high risk groups with significant environmental exposures. Right, so I would like to conclude my talk leaving you the take-home message. Air pollution is one of the greatest environmental risks to health. 8 million dies prematurely per year due to air pollution, and air pollution is the known cause of over 3 million deaths every year due to ischemic heart disease or stroke, which is more than traditional cardiac risk factors such as diabetes, smoking, or obesity. The pulmonary manifestations will be diverse. The decreased lung growth is a well documented and well proven complication following exposure to the toxic dust and fumes, and they will cause asthma in children. So poor air quality will exacerbate obstructive airway disease and interstitial lung disease, and it will result in airway disease, infections, and lung cancer. Thank you.
Thank you, Chandana, for that very interesting topic on the airway, breathe, and lung, the respiratory diseases. Now the session is open for questions, and if there are any questions, you could ask from all the speakers. A question from Dr. Philippe. Just to find out about this nasal polyposis, we have fungi causing nasal infections, and in the tropics we do have so many other pathogens as well. How do we differentiate this in the asthmatic who comes with a blocked nose?
Well, the most easy way to find out whether your patient has nasal polyps is, of course, if you have an endoscope, you can look. But if you are a lung physician and you can't look in the nose, the best thing to do is ask whether there is smell. Patients without smell, no smell at all, so not a decrease of no smell, quite often it can be nasal polyps. So if you have a patient with a lung complaint and no smell, then there is quite a big chance that your patient has nasal polyps. And of course, it can be due to several infections or underlying exposures like fungi. In Northern Europe, fungi is less frequent, but the more you go south or around the equator, the more you have fungal disease, and it can be also very dangerous fungal disease in the sinuses, as you might know.
Thank you. Dr. Harjit, just I think you highlighted the use of theophylline in asthma, which is an absolutely controversial topic, but as in India, I think in Sri Lanka also we continue to use theophylline quite liberally, perhaps because of financial constraints. What do you think about the future of theophylline in the control of asthma?
So, like you rightly said, it would not be my drug of first choice, as I mentioned during the talk, but as an add-on therapy, it might be of help in a small subset of patients. What is important to remember is that when you're piling on drugs, it's very difficult to discern what is the difference you get when you add another drug. And if you possibly cannot find any specific benefit from addition of theophylline, then I would strongly recommend that you withdraw it as well. Because I think once we add drugs, we frequently forget to omit them when they don't work. And teasing out the response of each and every drug when there is a mix of therapies is extremely challenging. Secondly, in the acute situation, theophylline might be a good drug in certain situations, but it can also cause a lot of side effects. So in the acute situation, my concerns are much more than in the chronic use. Particularly if you're using sustained release theophylline, it's less likely to be an issue. You have to be worried in particularly cardiac patients where it can precipitate tachyarrhythmias. But as an add-on therapy, because like you rightly said, because of financial constraints, I would not be averse to trying it out.
Thank you very much. If there are no further questions, I think we can close this session. And yes, we have some certificates of appreciation for the speakers.
So let us, on behalf of the College of Pulmonology, Sri Lanka, let me thank all 4 speakers from the local faculty and overseas for their excellent contribution for this important session on asthma. Thank you very much.